good to go, Darren?
Yes, we're live now, Councillor Alden, thank you.
Brilliant. Good morning, everyone. Welcome to the January meeting of Health and Wellbeing Board. We will dive straight in. Darren, apologies for absence.
Thank you very much, Councillor Alden. Apologies have been received from Councillor Gledhill and Andy Millard, Andrew Pike, Pretty Sudd, Julie Rogers and Christina Jackson in advance.
Okay, thank you very much. Minutes of previous meetings. Does anyone have any comments on the minutes? Jolly good. Okay, well, we can take them as approved. Urgent items. I've not agreed to the consideration of any urgent items. Declaration of interest. Anybody? Okay, I'll take a second and just welcome Joe Cripps, our colleague from the STP, who has done Galleon's load of work on the emerging ICS designation and some of the nonsense about changing the boundaries. So it's the first time that board have their opportunity to show Jo our appreciation for everything that she's done. I would like to welcome Pradeep, who's doing a lot of work with dementia care. So he's our guest this morning for our item on dementia. And also welcome to Nigel Leonard, who's a regular attender, but EPA have done quite considerable work in terms of the rollout with the vaccine. I'm just trawling through my notes. And Stephen Mayo, Stephen, is this your first meeting having replaced Jane? Is that right?
It is indeed.
Well, we've had your wonderful company many times in the past, but certainly welcome in your new role.
Thank you.
Darren, are we taking the item on maternity services at BTUH first?
Di Sarker is going to be joining us in about 6 minutes, Councillor Alden. So I think we was going to take Joe Cripps' item first, and then Di Sarker, because she's joining us in about 6 minutes.
Joe, are you ready to present? Is that okay with you?
Yeah, absolutely fine. So I haven't got, this is just a verbal update. Thank you, Councillor Holden. Colleagues will be aware that it's NHS policy that all areas of the country are covered by a designated integrated care system by April 2021. Certainly a number of systems across the country have already been designated. We were invited to apply for designation and we submitted our application in December last year, which was kindly supported by all members of the Partnership Board, and in particular supported by Councillor Holden and the 3 Health and Wellbeing Board chairs across Essex, which was, I felt, a really valuable level of support for our partnership and the work that we've done to kind of bring everyone together. So the kind of process around application is you have to have a letter of support that's signed by your partner organisations, and then you have to have an application pack which describes kind of who you are, what you've done, what you're planning to do, what your key challenges are, etc. So we submitted that and kind of assesses us against a maturity matrix, which NHS love to have a maturity matrix, so we've assessed ourselves against that, and actually we have come quite far as a partnership over the past 12 to 18 months. So really good work. The application then has to be considered by the NHSE regional team, which it was yesterday, and they are going to make a recommendation to the regional executive team that the application is supported. And it then goes off to the national NHS England and Improvement team on the 16th of March, and hopefully they will support the application and will be designated as an integrated care system by April 21. You know, I suppose the question is, so what? And there could be many answers to that, but so what, I think, is it recognises how far we've come in terms of developing our partnership. It gives us additional autonomy, I think, from NHSE and I, and it helps us to kind of work together with them so that the regulatory relationship, which is obviously so important, is more of a collaborative and a facilitatory one rather than a kind of adversarial one. So we would hope to hear sort of mid-March that our application has been successful, and then we enter the new financial year as an integrated care system. Happy to answer any questions if anybody's got any.
Thank you, Joe. Does anyone have any questions on the current ICS application itself before we kind of move on to talk about the emerging issue with the boundaries possibly changing? Roger Harris.
Thank you, Joe. I just wanted to sort of, I think, pull out the point that I think the document, I think, described the relationship between place and system, I think, very clearly. And all the work that we put into the MOU over the last 12 months or 12 years, I can't remember which it is, stood us in good stead. And I just think that principle of subsidiarity was very well recognised within the document. And some of the comments that we'd made as a local authority about children's services and mental health services were definitely taken on board. And I think they were the document that went in at the end was much stronger than the document that it went in. So just again, a thanks to the team that put that together to recognise some of those issues that the local authority had put forward.
Thank you, Roger. Does anyone else have any comments on the ICS process? Okay, well, to update board, obviously we're in a situation now where there was a pronouncement of some kind from the Secretary of State where he indicated he was open to the idea of reviewing the boundaries. And about 3 years ago now, we did have the conversation when the STP boundaries were originally set. The boundaries did not make sense. They were very strange geographies. However, that was a fight that we lost then and there. So we have since laboured for 36 months to form the priorities for the partnership. I think we've got robust priorities. As Joe will know, the covering letter that went into the ICS designation specifically referenced having to restart cancer care and mental health as our great priorities. We've done this with a partnership. To now change the boundaries means that we would go for 6 months, a year, maybe 18 months of arguments around where the red line is drawn, having to bring new partners into the tent. And when we do, perhaps have a reshuffle of the key names and the key organisations as a part of the rather opaque way that the NHS goes about appointing people. This essentially means that as we come out of COVID, as we've got an intense backlog in cancer, an intense backlog in mental health, instead of talking about how we are going to reboost the system, we are going to spend 18 months having to pull apart the MOU that it took us almost 18 months to sign. I think this is an incredibly retrograde step. I've made representations along with MPs, Southend Council. I'm very grateful for our acute hospital colleagues supporting us. I'm ashamed who wants to suddenly put their hand up and say that rejiggling the boundaries is a wonderfully clever idea. Certainly, if there is anyone on board, do feel free to say it. Although, if you do say it, just bear in mind that Ian Wake will crawl out of a portrait behind you and attack you. Is there anyone who wants to make a case for changing the ICS boundaries being a good idea? Wonderful. My type of meeting. Look, Joe, going forward, can you just walk us through the time frame that we're looking at in terms of the current submission we've made for ICS application? Assuming the boundaries don't change, where do we think we're going to be in a couple of months' time?
So, assuming the boundaries don't change, we will hopefully be designated an integrated care system in March this year, and that will take up that title, if you like, on the 1st of April, assuming the national team support our application. Obviously, the boundaries discussion is one that's ongoing. We think it's important that we're recognised as an integrated care system as we are now, and if the boundaries do change, you know, we'll have to deal with that as it comes along. But certainly our intention, and as you know, Councillor Haldon, Mike Thorne's intention, is that we absolutely go hell for leather in achieving ICS status for Mid and South Essex. And what comes down the line we'll have to deal with as we come. I think what's really important, and as Roger has said, you know, what's really important to this partnership is its 4 places. and those places are not going to change even if there are additional partners that may join, you know, the partnership. So I think that focus on place, that focus on subsidiarity, that focus on ensuring that we're working together for the benefit of our population and not for organisations within it, is an absolute principle that we'll maintain. But you know, the boundary discussion is going to be out of our hands to some extent.
I think it will be to an extent, but following today's meeting of board, where no one's indicating that they think the boundaries changing is a good idea, I write to the Secretary of State again, because I'm aware that several letters have gone in from acute hospital colleagues, from MPs across the camp, from other top tier authorities. So my proposal will be to keep that pressure up. So Darren, if you're taking notes, if you could remind me to get that letter off sometime tomorrow. I'll write it, just give me a nudge to actually do it.
Indeed, Councillor Alden, of course.
Wonderful. Joe, thank you so much for your update. You are very welcome to stay for the rest of the meeting, but I'm assuming you have other things to do. So
I will dip off. Thank you very much. Thank you. Have a good day.
You're very welcome. Thank you, Joe.
Take care. Bye.
So she only would have been sat there trying to work out why Roger's not wearing it. But I think we've just been joined by Diane Sarkar, Senior Executive at our hospital, our collection of hospitals. She has a vast dominion under her. Diane's going to talk to us about the current issues with maternity at Basildon Hospital. Diane, the floor is yours.
Morning all, thank you for inviting me back again. So I thought it'd be helpful just to kind of update our progress on the maternity improvement plan and the section 31 progress, and then of course happy to take any questions. So we are reporting to our regulators on a monthly basis, both on our improvement plan and particularly on the section 31 update. So if I just look at the improvement plan to start off with, good progress has been made. There are no outstanding actions. In terms of the section 31 progress, you'll be aware, and I shared before, the number of conditions, and the first one was around the governance systems. So these have now been implemented. I guess the challenge for us is making sure they are embedded and sustained. So that's all in progress. We have had some external support from PwC that are supporting us to ensure that we are kind of have that additional resource and support, and to make sure that we're using kind of best practice. So that's been really helpful. As part of that, we've had the Freedom to Speak Up Guardian come into the unit on 2 days a week. And that's been, I say it's been helpful. She actually hasn't been really utilised, so that's, I'm not sure whether that's positive or not, but she's there, and she's there for staff to raise their concerns. Let's say there hasn't been anything raised with her as yet. The next thing was around the escalation of sick women and that handover process. Daily huddles are remaining in place. There's been really good multidisciplinary team attendance, and that's been supported by our audits, which again we feed back to the CQC. So that's been positive. I think in terms of the next one is around the staffing, and staffing has been a challenge, particularly over the Christmas period. We had quite a large number of staff either self-isolating or with COVID themselves. However, we did still manage to achieve one-to-one care in labour for our women on 99.3% of the time, and obviously that's the important thing for the women. Our other metrics remained positive and continue to go in the right direction, and that's what we report to the CQC. We did have to divert on 4 occasions in December, and that was due to capacity. but there was no negative impact on our women, and in fact there were no deliveries on either the Southend or Broomfield site as a result of that. They were antenatal inquiries, so that was positive as well. I guess some of our forward challenges, it is around leadership. We are still actively trying to recruit a director of midwifery, and I think I shared with you before, we've been out to recruit 3 times and have been unsuccessful in recruiting. We have now gone to a headhunters to try and achieve that. I'm not necessarily hopeful. They have informed us that nationally there are 9 director of midwifery posts out to advert, but we will continue with that. We are continuing to support our leadership team with individual coaching and team coaching to support them and make sure that we've got a career framework for those, but also to support them in these challenging times. We have also now got the support of NHSIE. They are supporting us on their maternity safety support programme, which is a huge help and benefit to us, and that's not just for the Basildon site. They are looking at Southend and Broomfield, although the focus at the moment is on Basildon. But for us, that's we're getting some excellent support, but also they can share with us best practice, which obviously will improve the care for our women. So they're still doing a bit of a diagnostic, but supporting us in leading the developments that we are doing. So I'll probably stop there. That's kind of a quick canter through, but I think the headlines are things progressing, everything progressing in the right direction. Our monthly reports and calls of the CQC aren't yielding any concerns. We are taking obviously the maternity improvement plan through both the Quality Improvement Board and SOAG, so it's getting that scrutiny, and obviously our head of midwifery and our clinical director report monthly to our board in terms of that scrutiny for the improvement plan. So happy to take questions.
Well, thank you very much, Diane, and thank you very much for joining us this morning. Before I open it up to general questions, I do know I had a meeting with Tom Abel just before Christmas where we did discuss the issue of some local authority concerns regarding the communication between midwifery and the hospital in general with children's services staff, making sure that we had a wraparound service in regards to the mothers who we feel were vulnerable. And I was told that there was going to be outreach to us to further that conversation. Sheila Murphy, our Director of Children's Services, on the line. Sheila, has that conversation taken place? Have the hospital reached out to you?
I'm not sure that they have. I'm not sure. Would that be you, Diane, or would that be somebody else?
I haven't. I've not been made aware of it, but I can certainly follow it up, Sheila. I'll speak to Tom and see what's happened.
Thank you. I mean, I had put my hand up before James spoke. What I'm interested in is how do you capture the views of the women that use the service and, you know, use that to actually help to improve. And also we have a Brighter Futures board where we do talk about children's issues. And I think you mentioned you were doing monthly reports internally. It'd certainly be helpful if we could have something a bit more formal to the Brighter Futures board, because we've got a number of colleagues there who could perhaps have a look at this in a bit more detail, and anything we can do to support to continue with the improvements.
Sure, no, happy. Thank you for that, because I forgot to mention. So we have appointed a midwife, actually, who's the head of women's and families experience and engagement. So really to focus on that, working with Maternity Voices Partnership. So really picking that piece of work up. And actually we had our first engagement event yesterday, 26th, We had 47 people along, some women that had already delivered, some women that were still on their kind of antenatal pathway, really working with us to see how we can improve the service, and really listening to them around not just the building, but actually the service delivery. So that was really, really positive. And Mandeep, our clinical director, Dr. Mandeep Singh, is looking at health and wellbeing in pregnancy, and really looking at that normalised pregnancy. So it's really great to have those women on board, and that was really, really positive. But I know Leslie, who's the lead now for Experience, she's really wanting to reach out to external stakeholders to hear and gain those views, not just from women, but other stakeholders as well. So that's a new post, and that's not just for Basildon, that's for the Trust.
Sheila, does that get to what you were after?
It does. I think it's probably more the link, a stronger link between yourselves and the Brighter Futures Board.
Yeah.
Because it sounds really interesting as well, having done that consultation event, this week. We'd love to hear what the sort of thinking is from that, what the outcomes are. If there's any reporting on that, that would be really helpful for us to have sight of.
If I get your details, Sheila, then perhaps we can touch base. That would be helpful.
That would be excellent. Thank you.
Great.
Thank you very much for your comment, Sheila, and thanks for that undertaking, Diane. Kim James.
Thank you, Chair. I just wanted to say that some of the work that Diane's talking about, we've been involved as Healthwatch. All three Healthwatches have been involved in some of the events that have gone on, and the planning and the feeding back, and making sure that any information that we receive from any of the residents, or feedback, positive or not, we make sure that's all fed in there. So we've built quite a relationship around that, and are doing some work as well. So we will be doing a local piece of work, but at the moment it's very difficult for any of us to do anything. But it is on our radar to put out there. But we do share information. We make sure that any events that are going on are put out into the public domain within Thurrock. So we are involved in it.
And I think those meetings that we've been having, actually, Kim, are really helpful, and certainly not just for maternity, but for the general patient experience lead. It is difficult at the moment, isn't it? But moving forward, there's some real opportunities there, as we've discussed, isn't there?
Yeah. Thank you.
James, are you on mute, or have you?
I was going to say,
or has James ducked out? Darren, can you see as the?
He's had enough of me already.
He's still there. He's on hold. Tell them
he's on hold. We'll just try and work that out for him a second. Roger, won't keep you a moment.
Okay, might just be a connection problem.
Are there any other questions that anybody wants to ask? We're certainly seeing women come through with COVID now, and those numbers of those women are certainly increasing now, as I guess we would expect. But no major issues with them, health issues at all, which obviously is positive.
When are you expecting CQC back in, Diane?
I don't know. We have been told generally that CQC, unless it's a responsive review, are limiting their number of inspections until kind of the new financial year. So hopefully we don't have any dreadful things that happen that causes a responsive review, because it would be nice to, I think, we're well on track with the actions that we've taken. The challenge is sustaining them and making sure they're really embedded, and making sure all the staff are completely signed up to everything, and that's the challenge. And as I said before, some of the cultural change, it doesn't happen overnight, and it does take time. So in some ways, the longer that time is, until when they come back in, that the more helpful I think it is. But Yes, I don't know, and certainly as they generally that they've said they were going to limit them until after April.
Okay, I'll just take over the chair while Darren is trying to find out where James's his connection has gone. Helen, you had your hand up.
Hi, thanks. Thanks, Roger. I was just going to say, Diane, it might be worth mentioning while we've got a minute that for the function of the local maternity management system, chaired by Rachel Hearn as well, and there's an opportunity there for, I know our public health colleagues are part of that membership, and myself are part of that membership with sort of mental health hat on as well for perinatal. So, and we had a really helpful conversation last week around the impact of COVID-19 and some of the information materials that's been helpfully published, particularly for our Black and Asian minority ethnicity groups, which are particularly at risk from the COVID-19 and promoting the vaccination, etc., etc. So there are some good materials that we will share through the Brighter Futures newsletters, etc., etc., and to the membership so that we can spread that message far and wide, because it's a really important one at the moment.
Yeah,
okay. Thanks, Helen. Anything you want to respond to on that, Diane? Or I think that was just.
No, I'm on the LMNS as well. So it's you know, again, that would be a really good vehicle to move things forward. And you know, particularly with maternity, it's not just an acute provider, is it? It's the whole system service provision. So it's important that we all work together, and I think that's going to be a really good vehicle to do that.
Okay, well, thank you very much, Diane, for coming back. This is obviously an area of considerable interest for both the Health Wellbeing Board and Scrutiny Committee, and I'm sure we'll be inviting you back later in the year again as well.
And Sheila, I'll make contact with you outside.
Brilliant.
Okay, lovely. Okay. Thank you so much for inviting me. Thank you.
No problem. Thank you. As I said, we're still trying to establish contact with James, so I'll carry on sharing whilst we find out what's happened there. So,
how quickly you search, Roger?
Oh, right. Okay. we have. I
hit a couple of wrong buttons, and you're in my grave like anything.
I just assumed one of your nephews had pulled a wire out or something.
I would love to blame a baby. That was actually me.
Oh, right. Okay, back to you, Jane.
Well, Diane's gone. So that was a lovely session. I'm glad she'll be linking up with Sheila to make sure there's better interaction with Brighter Futures. Moving on, item 7. Roger, is that for you to lead on the health and winter care plan, or just general COVID pressures?
No, Ian is going to do a short update on the sort of wider epidemiology, and then Mac, if Mac is able to join us, I know he's on the LRF, we'll do a bit about the health system pressures, and then I'll come in around social care. So that's the proposed order. Ian to kick off, Mark, Mac, and then myself.
Sorry, just bear with me.
There you are, Ian.
Okay, so in terms of the epidemiology, I think we've come over the peak now, the second peak. The metrics really for the past 2 weeks have all been pointing in the right direction. Our overall rate per 100,000 as of 5 p.m. yesterday was 472. So that's the first time that we've been under 500 since the 10th of December. So that's really good. That ranks us in terms of upper tier local authorities at 39th, which again is a reduction from the day before, where we were 37th. And as you may well remember, we were first for a few weeks over the Christmas and New Year period. So again, that is welcome news. Our rate in those aged over 60 continues to fall as well. As of yesterday was 315.2. Test positivity, the proportion of tests undertaken that test positive also continues to fall. We were at around 28% at one point towards the end of 2020. That's fallen now to about 13%. So we can see dramatic reductions in the absolute numbers of tests coming through to my team each day. It's around 150 a day at the moment that are positive, down from over 400 at one point during Christmas week. The numbers of tests undertaken has remained relatively stable. It's dropped off a little bit over the last couple of days, but over the last week has remained stable. The uptake in terms of our asymptomatic testing offer for working age adults, it remains really, really strong. We're getting in excess of about 1,200 tests a day at the moment, which is really positive. About 2 to 3 times more women than men are testing, so we are doing some targeted comms in terms of men, and middle-aged and older working age adults are more likely to test than those in the 20 to 29. So again, our comms colleagues are doing some quite innovative stuff on YouTube and Instagram, where younger working age adults are more likely to access. But in general, I think it is all pretty good at the moment. We still obviously have quite a high level of absolute infections, but I think that we're starting to see that the lower rate is translating into reducing demand on our health and care services, albeit at still quite a high level. Happy to stop there and take any questions, or I don't know whether you want to do questions at the end, Joe.
Does anyone have questions for Ian thus far? Seeing a general shaking of heads. Oh no, sorry, Freddie.
Yeah, just a quick question. In the number of terms of infections, do you have a percentage breakdown of the ethnic minority communities?
I'm not sure it's the absolute answer to that. I'll need to check with our surveillance cell. Let me come back to you in writing on that one.
Okay, and that'll be useful. Thank you very much.
I'm not sure whether we get that data or not.
Okay.
I would just say, just on the BME community, I did have a email from Thurrock BME yesterday asking if I would join a virtual meeting with them to talk to the BME community regarding fears about the vaccine and encouraging take-up, etc. I'll be doing that at the start of February, and I'll be asking anyone who is interested from either the CCG or Public Health, if they wish to join me, they're more than welcome. So I know specific attention has already been given by the Public Health team and the CCG to the BME community on both vaccination and also on test and trace. So it is certainly an area that we've got a very clear focus on.
I do know the answer to your question, and the answer is yes, we do. So I've just recalled this, but it's so badly recorded in the data set that we get through that we ended up taking it off the surveillance dashboard. It was on there a few months ago, but the data wasn't making much sense, and there were many people coming through without ethnicity recorded. So I don't think we have it in terms of what's provided to us. We don't have it recorded in sufficient granularity and depth to be able to analyse it, to make sense of it. It is the answer.
Councillor
Okay, did you want to
I'll be interested
more
in your
carry on with Ian, or?
Yeah, sorry.
Sorry, Freddie. Ian, have you got more presentation to proceed with, or
no, that was
going to go on to the winter plan side?
Happy for you to go on, Chair. Thank you.
Okay, Roger, is that you now, or?
No, I think Mark's going to do a sort of, it doesn't look as if Mac's been able to join us yet from the LRF SCG meeting. So I think Mark's going to just do a bit about the NHS system pressures, and then I'll do the care system pressures.
Brilliant.
Okay,
Thank you, Chair.
Mark.
Thank you, Chair. So yeah, I'll provide a kind of like a broad overview of the kind of health system response during the kind of peak of the crisis. As people will know, we declared a kind of internal kind of critical incident, kind of highest level of kind of incident, as a reflection of the extreme pressures felt, particularly over that kind of Christmas New Year period, where we saw kind of very steep rises in admissions and kind of needs for kind of critical care capacity and oxygen capacity. So, I guess as an overview, I think I would like to start just by thanking all of the kind of frontline staff that have been involved in such a kind of incredible effort. I think for most people, it's been the kind of most extreme and prolonged pressure that people have ever experienced working under, and I don't think we can underplay that or thank people enough for that kind of enormous hard work. And I think it's also the kind of resilience that we have shown in Mid and South Essex has been largely because we've come together so well as a system. So across clinical staff, social care, our voluntary sector, our volunteers, I think it's only by those efforts that we have absolutely maintained the kind of resilience that we have. So again, I don't think we can we can state that enough, nor the kind of need now to really focus on kind of staff well-being. So, as we're moving out of that kind of peak of the kind of COVID response, recognizing how hard people have worked for so long and the real need to kind of focus on making sure that we support people and support people's mental health and provide the kind of support that they need as they kind of come out of that kind of peak kind of demand. So I'll provide a kind of a broad overview kind of by sector, I guess. So so obviously the hospital experienced extreme pressure, very high levels of COVID patients. At one point across the 3 hospitals, nearly approaching 1,000 patients who were COVID positive. Great many of those requiring oxygen, and the kind of pressures on the kind of infrastructure as a result of that. They were managing, of course, high levels of sickness through COVID and isolation. So it was a real a kind of a combination of the kind of increased demand through the door, but also the kind of workforce issues that people will be familiar with. As I kind of alluded to before, I think that the resilience we showed was a credit to all of the frontline staff that work in the hospital and the wider system that kind of came together to kind of really pull together and particularly focus on the flow out of the hospital. So within Thurrock, we which I'm sure Roger will touch on, but kind of opening up of Oak House as the kind of red site. We increased capacity at Brentwood Community Hospital with the support of the Army. We redesignated Meadowview from a kind of dementia ward into a further designated site. So really, from a kind of bed-based perspective, pulling out all the stops to make sure that that there was the capacity in the community to discharge patients out of the hospital when that was ready to happen. It wasn't just the kind of bed-based response, of course. There was a massive effort from all of our kind of community providers. So there were a number of initiatives. I think we provided really robust, collective, multidisciplinary support to our care homes, whether that be through that kind of GPs, through the kind of community services, and very much in partnership as a local system, making sure that the kind of discharge processes, particularly the respiratory pathways, the kind of like the hospital at home model and the virtual ward model was kind of well coordinated. We saw very significant rises in the use of 111 during the kind of COVID period. We kind of mobilised the Think NHS 111 First model, so that we could kind of book people into A&E if they required it, and we could sort of steer people away from A&E if they didn't require it. So during the kind of and really just to make sure that the waiting rooms in A&E weren't and therefore creating a kind of contamination, a kind of risk, a transmission risk for COVID, and that was mobilised really rapidly in line with the kind of national kind of protocols, and was supportive in diverting a number of patients away from A&E but also kind of booking them into A&E when that's required and reducing their waiting time in A&E. We've obviously seen the pressures not just in the acute sector. We've seen a very high demand through mental health services. We've seen a higher acuity of patients in the mental health wards. I think through the last peak, there was the ability to kind of discharge a lot of patients safely, that there was less ability to do that this time, and managing the same workforce and outbreak pressures that we saw in other parts of the sector. And I think it's a credit that mental health services kind of remained open throughout that time, with a kind of real focus on making sure that kind of crisis support was available for people to use it. IAP services very quickly kind of changed model and were able to provide kind of virtual support, and we still have very low waiting times for those IAP services locally, which again kind of credit to the providers for being so innovative in changing the model of care so quickly. From a primary care perspective, we have moved kind of reprioritised the kind of primary care model. Again, sort of like moving away from some of that kind of long-term condition management to making sure that there is the capacity to provide the kind of respiratory support, but also massively, as you can imagine, the kind of the vaccination program. So that vaccination program is going very well locally. I know Nigel's on the call, so he might want to talk about the kind of the EPUT mass vaccination site, but from a primary care perspective, we've obviously been focused on the 2 PCN sites at Stifford and Chadwell, and the 4 priority groups that we're working towards completing vaccination rollout by the middle of February. So that effort continues. We're on track, with the caveat that it's obviously dependent on vaccine supply, and the kind of the guarantee of vaccine supply is still at quite short notice, but we're working through that as we go forward. And then I suppose, yeah, just lastly, just picking up on what I started, or one of my earlier comments. EPUT launched on Monday the new Here For You staff wellbeing service. So this is a kind of like a 24/7 kind of helpline for health and social care staff. It's available to the kind of voluntary sector, social care, so residential care, domiciliary care, primary care. So it's a real open access service for health and social care staff that are experiencing kind of wellbeing issues during as a consequence of kind of COVID. So so just really good that service has launched. That will be a really good route in for kind of assessments of needs, and then kind of onward referral, whether that be kind of through the kind of priority booking at IAPT or other kind of offers. But I guess as we move from that kind of peak of the demand, I think this is the time where we really need to kind of capture that kind of staff wellbeing and really support people to come forward, because we know that kind of health and social care staff are some of the least likely staff to come forward for help, even when they need it. So I'll stop there, Chair.
Thank you very much, Mark. That's very helpful. I certainly think we all pass our heartfelt thanks to the staff who have been working excessive hours. I think we had the conversation about ICS designation and making sure that the mental health system is really restarted in the manner it should. Perhaps we need to have a separate conversation about making sure that IAPT has a certain amount of capacity purely reserved for the members of staff who have been specifically overburdened during this process. Are we aware of any conversations about making special provision in place in this regard?
Yeah, shall I respond and then I'll hand over to Nigel? But yeah, certainly locally, the health and wellbeing staff have a priority with the local IAP service, and the kind of Here for You service is also reaffirming that kind of prioritisation for health and care staff. So absolutely, that's the intention and what we've mobilised locally and through this offer.
Thanks, Mark. Nigel, do you want to come in?
Thank you, Chair. If I can just add to Mark's comments, certainly across, certainly within health, we as a system, our psychology team have actually been identified to provide further direct support to healthcare workers, irrespective of which organisation they work for. So there is that access already available as well.
Thank you, Nigel. Has anyone got any general comments they wish to make on current pressures? Anyone at all? Oh, Sheila.
I just wanted to make a bit of a plea again on behalf of children's services, and probably in particular our SEND children and learners. If any children's sort of health services are being redirected away from working with children during this current crisis, and this lockdown, if we could be made aware of that, so that we have to really sort of adjust what we're doing in other bits of the system, if you like, in children's services. And in the first lockdown, a number of children, we've been playing catch up really with their needs. So I know they're not in respect of the pandemic, you will make decisions about that, but I just think I'm hearing a little bit coming from our SEND colleagues that we may not be able to progress some of our EHCP plans and or reviews because we don't have currently the input from some of our children's health staff.
Thanks, Sheila. Who's best to reply to that? I mean, Mark, I assume.
Yeah, so I think we initiated some conversations this week around bringing the kind of the system together. So kind of just conscious that we need to, there's a number of services that are provided by NELF, so the kind of school wellbeing service and the mental health support teams and UMS and the community paediatrics, universal offer. So I think we're really keen to kind of join all of that up and have a kind of like a children's kind of performance and kind of operationally focused group that brings all of that communication together, because I think there's probably a number of meetings that are happening in different forums, and I think there's an opportunity to join that up a bit more. So so yeah, we're on it, and we're kind of just working through some dates to kind of bring that together.
Wonderful. Thank you very much, Mark. We've got any other comments?
Yeah, Jill Burns from NELF, I think, has got a hand. I don't know if you could see it.
Oh, sorry, I'm just scrolling through. Oh, there, Jill. Please go ahead.
Oh, hi. Thank you. Just on the back of what Mark said, obviously we're all very preoccupied with making sure that we try and do a very delicate balance at the moment. Sorry, my phone. Do a little bit of a delicate balance at the moment, because we do have an obligation as a trust to meet all the directives of the Matthew Wynne guidance around what services we must prioritise during COVID, etc. That being said, obviously I meet with all the assistant directors on a weekly basis in relation to our general children's provision across the piece. And we are very clear. We know there are pinch points that have been caused by COVID. However, we're very assured from a clinical perspective that, you know, any high risk cases, any SEND children that are of concern to us, any children that have been long waiters, our mental health children are all being seen and triaged rapidly through our SPA as per normal. So we're all very cognizant of the whole COVID impact, but we just have to continue to do as best a balance as we can at the moment.
Thank you for that, Jill. Stephen.
Hi, I think it's also worth noting, away from direct service provision, we've also ring-fenced and protected, apologies that's next door to having building work, we've protected the children's safeguarding element, both in providers and also in CCGs, etc. So that has not been affected at all. We've kept that very separate and protected it.
Sheila.
I just think it would be really helpful for the whole of the system network in children's services to know which services have been diverted, because then we can try and, you know, support, make other arrangements that we need to know, that we might need to make, but also have a sense of how long, you know, such services being diverted might go on for.
Who wants to come back in on Sheila's point?
Sheila, sorry, Councillor Halton, it's Jill here again. Sheila, obviously all that information is fully available. That's all the national guidance. We do have regular communications. Helen Farmer will be au fait with a lot of the detail of this. And I think what might help with some of this is the comment that Mark made earlier, where there's perhaps a little bit of a rounding up of communications across health, the local authority in relation to what kind of national guidance comes down and then how it's all implemented. I see Mark sort of nodding his head there. So all any changes that take place are changes that all our CCG colleagues would be fully au fait with as their national directives. But I think the meeting that Mark is indicating is somewhere that we would try and pull all that together as a system.
Sheila?
I mean, my comments are not meant as a criticism against anyone. It's just more of a, if we're all informed and we know on a local level. I know there's national guidance and we're getting quite a lot of that across the whole of the system, across children and adult services. But I think it is, so if Mark is saying that he'll pull together some kind of meeting where all the children's people can get together and be clear about, you know, what's happening, because it has impacts on the rest of the service and the system. So that's sort of what I'm asking for, really.
Yeah.
Mark?
Yeah, I think there is a real opportunity to actually reduce the number of meetings, but improve the outcomes and integration. So I think we need to kind of bring that group together, you know, map out all of the current kind of forums where different conversations are happening, and then kind of bring it together. And I think we will, you know, reduce some of the burden and kind of bureaucracy, but also improve the integration, and that will be good for the outcome. So yeah, it's in hand. We're just kind of working through the dates to kind of bring people together to look at what their kind of terms of reference would be, and how we can not add it as a new meeting, but actually kind of replace some of the existing meetings, but bring it together in a more joined up way.
Thank you. Jill, did you want to come back in?
No, sorry, I thought I had myself on mute and I didn't. No, I think that's absolutely fine. Yeah, I completely understand what Sheila's saying. I think it's obviously we've got, you know, a place-based approach. We're working very much as part of the system with all our Thurrock colleagues here, and obviously there's some sort of communication issue where that those conversations are not widely shared, which I think that meeting might fully address, because all that information we make fully available.
Agreed. Thank you, Jill. Does anyone have any final comments on this item?
Do you want me to do the care update now, James?
Yes, please. Sorry, anyone have any final comments before we move on?
Sorry.
No, brilliant. Roger, do you want to move on to care?
Yeah, thanks, James. Thanks, Chair. Just to echo some of the points that Mark was making about, I think there's been fantastic system collaboration over the past 9 months. And again, put on record my thanks to my team and all the frontline staff who have gone that extra mile over and over again. The second wave has felt, I think, a bit different than the first wave. I think we were quite successful in the first wave in terms of protecting care homes in particular, but the new variant did change the game, I think, quite a lot for us. And regrettably, we did have virtually every home at some point was experiencing quite a high degree of outbreak. And we're now only just recovering from that. So only about half of our care homes are currently green and out of isolation and able to accept new referrals. And at one point, we were down to literally in a couple of homes able to take referrals because they were all red and currently in isolation. We have opened, as people know, our designated setting at Oak House. That has been fantastic because they took all the referrals directly from hospital. And in fact, again, half of the referrals were from Essex because we were providing mutual aid to Essex on quite a regular and consistent basis. So I think it'd be fair to say that the numbers delayed at Basildon were very low from Thurrock. And the hospital flow, which was so crucial, particularly once the major incident had been declared, was I think fantastic in terms of the work that the hospital social work team, the contracts and compliance team, and also the Oak House and all the staff around that. I also like to pay tribute to our partners because I think they often don't get much airtime, but all our domiciliary care providers and our residential care providers also had considerable problems with staff either self-isolating or off sick. But again, they have also gone that extra mile in terms of making sure that people weren't stuck in hospital or stuck without any care. We're not out of the woods yet. We've obviously, I think the hospital admissions and the care sector is the last to recover. As Ian just showed earlier, that the transmission and the R levels are going down, but I think this one is going to have quite a long tail on it. So the hospitals are still at Opal 4. We are still in a major incident, and we're still having to make sure on a daily basis that we're making sure that there aren't any delays of transfers of care. In terms of going forward, I think we are going to have to position ourselves to prioritise how we manage the recovery period. I think we're all concerned about what is likely to be a very large number of areas of work that have just been put on hold for some time, and also future presentations. Obviously, there's been no evictions over the last 9 months, and we're very concerned about possibly a growing rise in homelessness. I think a lot of people have only had digital reviews, and we do need to start visiting people fairly soon again. And some services have been closed, so day services have been closed. We've been operating on a reduced level with our respite services. And I'm very concerned also that some areas like learning disability have most probably gone under the radar a little bit over the last 9 months with all the focus on care homes and older people. So we need to make sure that there are, in the recovery period, that we need to look at those areas that most probably haven't had that much attention over the last 6 to 9 months. So that's a very quick run through, Chair, the areas of concern. Still, still very intense. But again, the teams have been working fantastically hard, and the collaboration has been brilliant, both within health and care, but also with our external providers as well.
Thank you, Roger. And I think once again, we send our thanks to all of the workers who have been toiling away so hard. I think in terms of what you mentioned regarding recovery of learning disability, I would encourage everyone to make sure their organisation responds to the consultation on the economic recovery strategy, which will be going to Cabinet soon. I've chaired a working group looking at the economically vulnerable, care leavers, the learning disabled, but it's absolutely vital. NHS colleagues do feed into the areas in which economic recovery needs to happen. As Roger says, we've been very preoccupied about certain areas in this crisis, adult social care being one of them, and economic recovery, we're very preoccupied on the unemployment figures that have been driven by retail breakdown. That type of recovery will not hit the learning disabled, care leavers, the socially isolated, those with acute mental health issues, those with physical disability issues. So please, everyone, do give due regard to that strategy. I want to make sure it is very, very broad and very targeted, and not just a what's the expression, a mile wide and an inch deep. Does anyone have any comments for Roger regarding the care situation at the present time? Okie dokie. Roger, Mark, Leonard, thank you all very much for your update. Now, I don't think Mac has joined us, which is okay. I don't think we're especially after Mac for anything in particular now, are we, Darren?
We're not cancelled, and Matt's not providing a specific agenda item at this stage. He was just going to contribute to this item if he made it to the meeting.
One. Thank you. Do we have colleagues with us about the STP primary care strategy? Brian or Ashley?
Thank you, Chairman. This is Brian.
Oh, thank you, Brian.
Would you like us to kick off?
Yes, please. I think most colleagues have had a précis of the primary care strategy in various fora. So if you could just give us some headlines so we could dive into discussion, because I know there are quite a few comments people would like to make.
Okay, we have a short presentation which I can go through fairly quickly. We didn't circulate a full paper for this meeting because we're currently editing it, almost rewriting it. So I think what suits from what you've said would be to hit the highlights and particularly how it's going to affect interaction with local authority, and specifically Thurrock, what you've done already and maybe doing in the future, if that's okay. Either Ashley, who's working closely with me on this, or Darren have the presentation.
Wonderful. So Darren, if we can pop the presentation up. Brilliant. I assume everyone can see that. Okay, the floor is yours, okay. Brian.
Many thanks. As I said, I'm clinical lead on this short project, approximately 6 months. I've been asked to work with the partnership on this. My normal job, I'm a GP and I'm chief exec of the LMCs, the local medical committees across the county. Ashley King is also leading on this on behalf of the partnership. Purpose to summarise progress since June 18. You'll remember Thurrock CCG was one of the 5 to approve the previous primary care strategy, take into account changes in that time, some of which you've just been discussing, and improve patient input and improve our integration, particularly with local authorities and community providers. Next slide, please. So you will know of these, the NHS long-term plan from January 19, which pretty much followed the direction we were going in because we anticipated it. The primary care network formation has been the big change in primary care. Primary care networks, PCNs, are now very much the vehicle chosen by NHS England to drive forward primary medical care and integration with health and social care in general. The NHS England is focusing very much on networks rather than individual practices. That you've probably noticed that already, and the additional roles, etc., are all going through networks, not practices. COVID-19, no one predicted, but that's been the biggest strategic change clearly in the last 12 months. Next slide, please. The principles I won't dwell on. We will be focusing on practices. System integration is a biggie because it's impossible to ignore. The COVID crisis has, if anything, tested the system almost before it should have been ready for it. And I think in most places, people have stood up and done pretty well. The crisis has forced people together, thankfully. I mean, people across health and also health and social care. It could have been quite divisive, and I don't feel that has happened. The workforce, there's a concentration on workforce. Our concern over the current vaccination process is initially supply, but at some point our workforce is going to start failing. So that's a bit of an issue. Next slide, please. So we're trying to focus on two very key issues. One is networks. We want to improve their management and admin capacity. We want to, if at all possible, add in the skills currently held in CCGs. So the people working there will be better at integrating with local authorities and community providers than GP teams. So we want to improve both the management capacity and their clinical capacity. The next push is partly centered on mental health, which has been lagging in this plan so far. We also want to introduce a local or micro commissioning role, so that in the new proposed integrated care systems, which, as you know, are currently mapped across Mid and South Essex, that some commissioning decisions are held at a local level. I think particularly for places like Thurrock, which has specific needs, that could be very useful to be done by networks in their communities or groups of networks. Next slide, please. The other area we're focusing on is, you will have realized by now that because of the COVID crisis, the entire system has stopped doing a great deal of what would be regarded as normal work. The hospital system, but also primary care. At one point, sitting in practice, but it's happened more than once, patients don't want to see us. Some do, but many don't. And many patients are frightened to come anywhere near healthcare, and certainly frightened to go near hospitals. That is backing up a huge unidentified need. Also, patients who are referred by primary care cannot be seen in clinics. A lot of business, if I can call it that, both in primary and secondary care, is being done over the phone or by video. But there is a gap, a care gap, and a huge number of patients who have identified needs by their primary care GPs, but they can't be seen at a time or within a time that would be ideal. So managing those patients and making sure they don't deteriorate while they're in the middle of the system is a key thing for us. We're trying to do that via what we're calling a guardian service, which would be specifically responsive to patient needs, and would, we hope, improve communication between primary and secondary care, and patients would be able to plug into this so that they can find out where they are on the pathway, report any change in their condition, and also make sure that any necessary tests, diagnostics, scans, x-rays, etc. are done and reported to the clinicians that need to see it. We know this is being done in part across all systems. We think it needs to be done in an organised way. This is not to create some sort of new barrier or new service. This will be all virtual and is simply there as a communication and information hub. Next slide, please. Supporting the workforce, I have mentioned, and you've mentioned it in the discussion I heard coming up to this. We're introducing a support and mentoring service for both GPs and for practice managers, who are often a forgotten group, and focusing on trying to retain and recruit GPs. We're training more GPs than ever before, both nationally and locally, but a huge number of them are either going elsewhere or are going into practices and leaving quite quickly. Our retention is poor, and our number of GPs is static at best, and those who are partners running practices at a local level is still dropping. Other updates that we'll do from dental, pharmacy and optometry colleagues, as I mentioned before, integration with community providers and local authorities is something which is being done at local level, and you can tell me more about than I can tell you, because it's something we're working on at present in our rewrite of the plan. Also, digital change, which I mentioned, a huge switch to more than 70% of non-face-to-face appointments. That will rebalance at some point, but the change to more digital activity and Communicating with patients that this is the normal way forwards, I think it's going to be a major challenge. Public health and population health management, you have led on in Thurrock, so I'm certainly not going to teach you about that. I've already mentioned integration. Next slide, please. This just runs through what we've done so far, and we're pretty much up to date. As I say, our integration with local authorities could be better, and we want to put in the plan examples of where this is working well, and if you like, spread good practice as much as possible. But a lot of this will be done by people like yourselves. Next slide, please. Quick conclusion. We want to come out of this crisis. The review of the strategy will be end of March, finish the end of March. We want to come out of this stronger than when we went in, with better interaction with our partners and more of an idea of where we're going in the future. The system in the NHS almost certainly will be formalised within integrated care systems, probably by April 22. I'm told a white paper may be coming as early as February. So those that make decisions have already made the decisions, and that is the direction of travel. Our job is to strengthen the bottom-up integration as much as possible. And I'm very happy to take questions, and any difficult ones I shall pass to Ashley.
Thank you very much, Brian. I'm sure there are going to be lots of questions from the floor. If I could just stir the pot slightly just to begin with, I suppose my automatic concern is, given the primacy of place and the importance that the partnership has put on place, why would we at a system level wish to have a primary care? Because a primary care strategy is very much a local mechanism, a local automation. So why do we want it at a system-wide level? It's like having a school recovery plan for a school in special gets designed at the regional level. So could you just give us some reassurance that why the system is so interested in primary care? I mean, I know not there aren't many colleagues in any STP as Thurrock. I get why some colleagues may need a bit of help, but certainly in Thurrock, we're quite pleased with how primary care is developing.
Yeah, it's a good point. The system, the ICS, the way we're reviewing this is to reinforce what you've been doing in Thurrock and people have been doing in other, as they say, places. So the local alliances, the places, the directors that will work at that level, we think that's where the real business will be done. And we're deliberately doing the papers so that it will devolve as all power possible to place level and to network level. The NHS has a tendency to centralise, and becoming a formal statutory ICS, power will start to move to the top. We're trying to move this, and it's not being opposed, into a paper which says in this area that won't happen. The key decisions will be made at network and at place, and that means in CCG or Thurrock level for this meeting. So we're trying to make sure that that's written in before any formal integration happens.
Right, thanks, Brian. Let's go with Ian Wake, then Roger Harris, then Mark Tebbs.
Yeah, a couple of points. So the first links to what you just said, Chair. So I think there's huge opportunities with the PCNs to use that as a place-based locality planning footprint to integrate all of the transformation work that we've been doing that moves much broader than primary care to include adult social care and the third sector and strength and asset-based approaches in the integrated medical centre. So it was just some reassurance that we won't get this centralised model and that transformation and description can continue. And secondly, I think where there is huge merit in looking at primary care at system level is on the money. So we know at the moment there is a huge inverse care law going on in primary care where the practice populations that are the most deprived tend to get the poorest ratio of clinicians to patients. And is there an opportunity through this strategy to try and understand and address that in terms of, as a system, how we are allocating funding flows?
Would you like me to answer that straight away?
Sure.
It does relate to the first question, and I can see the anxiety. I work in primary care, and my idea of integration is completely from bottom up, and the partnership knows that when they asked me to help out with this, so that if they were planning a system-wide across 1.2 million people, this is how you do primary care integration. I don't think they've made that decision because they're not going to get it from me nor from Ashley and our colleagues, and none of our CCG colleagues are planning that way either. We want as much as we possibly can to keep things at a local level, and not centralised, because as I said, the NHS in England particularly does like centralisation. The inequity bit and the inverse care, you're correct. The network funding does do quite a bit to try and equalize that. It's never going to be perfect, and one of the things which we're going to address on a separate project is looking at current recruitment into networks, because in some areas it's been very successful and in some not so, whereas the formula from the centre, and this is national, says everybody gets the same sort of workers for their population, but the actual recruitment into that has been quite patchy. And the funding is being pushed down to network level. It should be a driver to improve that, but you're right. In some areas, you have to work harder to get people to work there. There's no doubt about it.
I mean, there's two issues. One's about attracting workforce, and one's about funding. But if we run on a formula where everyone gets the same, depending on population size, we are commissioning for health inequalities. Because what's beyond all reasonable doubt is that the need between different practice populations differs depending on a whole range of other socioeconomic and lifestyle factors.
Yes, it does. And I haven't seen anything which moves more funding into more needy areas. No, because the funding is national, driven by national contract.
Roger, do you want to come in?
Thanks, Chair. I just wanted to build, I think, on the previous two comments, and I think we want to try and move away a little bit from having a hospital strategy, a community strategy, a primary care strategy. And I know there will need to be specific primary care elements, but I think we've tried to, devise a place strategy in which where there will be a clear primary care element within it. And so that we look at the workforce, for example, as a whole. So, I think we've done a lot of fantastic work about, paramedics, around healthcare assistants, about local area coordinators, social prescribers working as a whole team, and not sort of carving them up into primary care staff or community staff or hospital staff. So I think, and I know you sign up to that, Brian, as well, but I just think we need to not build on where we I think are achieving some notable successes now, and I think try not to, I suppose, carve it up into primary, community and hospital too much, but talk about how that place strategy can utilise the resources in both workforce, financial, buildings, whatever it might be, in a different way.
I think in trying to do something for the system, we have struggled, and we are trying to improve a better picture of what is happening at place, because that's where we want decisions to be made anyway. And none of this paper in any way takes away from that. It's the one thing we want to build on. But in doing it across the system, I'm talking to people like the people at this meeting who know far more about what's happening in Thurrock than I do. So the last thing I'm going to do is tell you what's happening in Thurrock. The workforce issue is key. Paramedics are an interesting one, because when primary care realised paramedics were very useful in primary care, the ambulance service complained because we were stealing paramedics, which is a really good example of how we shouldn't be working together. Since then, they've changed their training, and in many areas we started to work on things like rotating posts, where staff can work in different branches of the service, and I think that will spread. We also think things like the Guardian service, which, as I say, is really just part of integration. It's It's not a building where people are going to work and have a badge. That should encourage better collaboration across all sectors and should develop skills which link secondary and primary care. So we have primary care physicians who are doing more specialist work, they've got special interests, and also consultants and nurses from hospitals who have more experience of working at a community level and therefore in the wider health and social context. But it's not easy, and we do have a tendency to drop back into our silos. So it's a fair point.
Mark?
Yeah, I think the risks of centralisation can't be underestimated, and I think to come back to that kind of bottom-up approach and how we integrate locally is, we need to keep on doing that. But I also kind of think that the kind of strategy is very needed, because we need a really strong voice around primary care at all levels. And I think without a strong strategy at the kind of health and care partnership level, then there's a risk that that kind of voice is not heard in the way that it needs to. So and I feel very reassured by kind of Brian's kind of presentation today, that this is not about sort of centralisation. This is about both having a strong voice at kind of health and care partnership level and strategic level, but not in any way taking away from local bottom-up decision making, or indeed the integration of care locally. So I'm very reassured by that. We are also kind of in the process of kind of having our second primary care commissioning committee. So the kind of primary care delegation was confirmed, and so I think that gives us a really strong local focus for primary care. So my sense is that the kind of we need to be operating across all of those levels, and particularly in relation to things like money. So we kind of need to be able to show the kind of combine, if we're going to transfer money from the acute to primary care and community, for example, we need to be able to demonstrate the impact of the totality of primary care. So I think it's I think the strategy is needed. I think it's taken the right, and I think it will help to be able to show the total impact of primary care on care pathways, as well as kind of support that local decision making.
Thanks, Mark. Brian, do you want to come back in?
Yes, I wasn't going to, because Mark hasn't specifically asked a question, but he did raise something which is crucial. One of the things I'm currently working on, which has not been in the paper so far, is about that primary and community care voice in the system. It's quite ill-defined how an integrated care system, which covers a large population, how it's going to be set up, how it's going to work. At the behest of the CCG chairs, they've asked me to put into the strategy some thinking about how primary care, how place representation, if you like, fits within the system. And I've been talking to colleagues in Greater Manchester who they have a different system to us, but they're further down the line with this, and they're working very closely with local authority colleagues. In fact, the integration in Greater Manchester was led by the local authority, not by health. So I've been talking to them about how they're doing it, and I'm trying to put in the paper at least some options or suggestions about how a voice for primary care, and that would mean almost certainly place level, how that fits into the system, and how as much as possible that controls the system. Because like Mark, I fear the tradition of NHS England, which talks about delegation, talks about all power to the bottom, but the danger is you turn into a Soviet system where all power is actually at the top and right in the middle. It's still in draft form, and Ashley, who's working closely with me on this, he hasn't even seen that bit. I'll share it with Mark and his colleagues, and feel free to share it with local authority colleagues, because I think your input will be better than mine. So if I put in something that's daft, you'll tell me.
Thank you very much, Brian. Any further comments? Just looking at the key strategic areas, I mean, key strategic area 1 does make an awful lot of sense, focusing at the PCN level. In terms of key strategic area 2, the scope of primary care, I do very much note your comment about the referred but not seen. Certainly one of the things that I'm very concerned about is the overuse of pharmacology by GPs, certainly in mental health cases, just putting someone on a box of antidepressants and then simply not conducting follow-up checks. So could you just flesh out slightly how you envisage that working? Because obviously that is very much to do with the local CCG relationship with public health and with the practice to make sure we can go after those data issues. So how do you see that developing? And also the Guardian service seems very exciting to me. But can you just explain how that wouldn't end up treading on the toes of Healthwatch? Because we certainly have an extremely strong Healthwatch in Thurrock, and I wouldn't want to see some manner of duplication.
Thank you. Just when I thought I was going to get off relatively lightly, your first question on individual treatment of patients, particularly mental health issues. This isn't going to interfere with the relationship between individual patients and their GPs or their practices. What will happen with us working in networks and then in networks up to place, etc., is there will be much more peer review. Practices will speak to other practices. Issues such as mental health will start to get more prominence because, if you like, there will be decisions and peer pressure to raise standards for particularly vulnerable patients. And I think that is inevitable. I'm not saying everything's going to be perfect, but I think that should improve because the more we work together, the more there's peer pressure and the more there's interaction and communication. What I hope are outliers, where care is less good than it should be, starts to shrink, and you start to move people towards at least the centre, and also got to be careful because there's public health on the call, but also move the centre forward so that everybody is getting better care. But I think hitting the weak tail where care is not so good, I think can be done through this. Your second question was about Healthwatch. In no way the Guardian Service can interfere with Healthwatch. I've shared details with Healthwatch. It's not going to do that role at all. It's not a spokesman for patients or a representative or an advocate of patients. It should be a way of patients being able to communicate and get information better on their individual care. So it shouldn't in any way tread on the toes of Healthwatch.
Right, thank you very much for that, Brian. Any further comments from anybody? I'm not seeing any hands up. Right, well, Brian, thank you very much for your presentation. I think you've generally heard what I feel the consensus is, that primary care in Thurrock is going in the right direction. So we do want to preserve that primacy of local place, but certainly in terms of some of the efforts that you're looking at, I don't think anything in principle seems, outside the realms of what we've agreed in our MOU. Could I just finally ask, where is this going now? When are we going to get to the point where we've actually got a formalised battle plan that has to start getting signed off by governance structures?
Plan is for the partnership board to sign this off in March. So there's time between now and then for this to be circulated to key figures, certainly at local authority level. I'll talk to Mark and possibly Darren about, or go through Mark to make sure we're circulating this to the right people, because I don't know your system, and there's no point me saying I've spoken to Mr. X if Mr. X wasn't able to circulate it to other people I should have spoken to. So we will do that. I'm not about to try and discover somebody else's system, but we will make sure that this is fed in so you can have local input. And should you want any more than that, we will do our best to supply it.
Thank you, Brian. Roger, when would you suggest would probably be an appropriate time for this to come back here? Because ideally, the most appropriate forum would be Health and Wellbeing Board for Thurrock.
Yes, I think we need to just take that offline, James, and maybe Ian, Mark, and myself, just to sort of map out a timeline for this. If it's going to the Health and Care Partnership, we signed off. We may not have another Health and Wellbeing Board before it goes to the Health and Care Partnership, but leave us to take that offline and plot out a timeline for it, James.
Thank you, Roger. Well, thank you, Brian and Ashley, for your attendance this morning. You're more than welcome to slink away unless you wish to stay here for entertainment purposes.
Many thanks. I have to go.
Thank you.
Let's move on to initial health assessment for looked after children. Stephen?
So I'll take this. Darren's included a PDF pack in the diary invite, and this starts on page 18. I do believe this is a follow-up update from a meeting, a health and wellbeing report meeting last year, around about October time, where there were a few questions asked. So just to give you a little bit of background, it's well known that for LAC children, there have been national, regional and local issues around meeting the statutory requirements of the initial health assessments. It's known that initial health assessments for these young children, looked after children, need to be performed within 20 days, with a 5-day referral from social care through to health to enable that assessment. Locally, in terms of follow-up review health assessments, we don't really have an issue with that, and Thurrock's local KPI is currently 100% from data reported by Public Health. So we're just going to focus on IHAs. IHAs are built around a physical and mental health needs assessment for these vulnerable children, and COVID has, we need to take the COVID factor into account for, from us, particularly around the second wave. We've looked at data for this up to October, and we can see, so this is on page 19, that there are some red patches, but overall it's, I would say, a slightly improving picture, and the data for November and December does indicate so as well. NELFT, it should be known that NELFT are meeting, when they get the referrals, they're meeting their KPI standards of these health assessments are 100%. Issues that have been identified on page 20 are things around communication issues, challenges for NELF in arranging and completing the IHAs, and there's a particular problem about young people that are placed out of area. There are issues around children where they change address quickly and it's not communicated back, or administrative difficulties around the court protection, and like children ending and information is not shared, for instance. So what has happened in response to this is system partners, NELFT and Thurrock's Children's Social Care and CCGs, they've started to have weekly meetings. And as I've said, that has sort of improved the picture, particularly in around November and December's data. We're also looking to develop a set-wide digital solution, and that will also help streamline processes. So we are optimistic around that digital solution. Further challenges are identified on page 21. So for issues like, issues around foster parents not taking their children to for their appointments, or interpreters not, basic interpreters not being booked for appointments, or even the young people are refusing to have their appointments. The three cases mentioned at the last board meeting that there were questions around. We have done a review on them, and it appears that these were short-term placements, and there were communication issues in feeding back to parties when these placements ended, which impacted on the KPIs and the performance at that point. It should be noted that because of COVID, and I think we've talked about it previously in one of the previous reports, was around to perform the IHAs. They have been conducted virtually, but we've had to put some ground rules in around these virtual appointments need to be risk assessed on a case-by-case basis. So that is happening. I'm sure there'll be some onward taking that forward. And actually, some of these looked after children have also welcomed these virtual appointments, but as I stress, it needs to be risk assessed because there has to be some physical examinations at some point. The out of areas tends to be an issue because other areas don't prioritise their LAC children. So we locally have taken the decision to bring them back and we arrange all that and now provide the initial health assessments. But it is problematic. It's problematic in keeping track of the children, making sure, particularly against meeting the deadlines of a 20-day review. And meeting the timescales around that. But having said that, in a year-to-date figures, it looks like it's an improving picture. So for Thurrock shows an approximately 74% of looked after children were placed within 20 miles of Thurrock. And this is an improvement in itself, and it's helping us maintain those statutory timeframes. I think it has been discussed, and it's part of one of the recommendations, which I need to just bring to the board's attention, that potentially a joint role, a LAC joint role between health and social care that would have a greater impact on that to support the existing designate LAC nurse to have greater grip on the process of pulling particularly these out of area children back for reviews. So we'd like to take that forward. And also there's discussions around taking a set-wide approach to the management of looked after children and IHAs. So the areas of improvement are detailed on page 22. And that translates into recommendations on the following page 23. So we're recommending to Health and Wellbeing Board that we bring a biannual update back to Health and Wellbeing Board, and it will have more data around improved timeliness of IHAs. We're looking at better communications and exploring that with our fellow commissioners. We're looking at to potentially explore and consider a joint funded role, particularly focusing on the out of area providers. We are exploring a set-wide approach to IHAs and also the embracing of the digital platform to support that. Clearly, if we go for a jointly funded post, there will have to be a business case because there would be potential cost pressures to both organisations. I'll end there. If there's any questions, I'll take those. We've got Helen in the room and also Michael, our designated LAC nurse, as well to support.
Thank you very much, Stephen. Any questions or comments? Sheila?
I'd like to echo some of this about the really good working between health services and children's social care. I mean, when we had Ofsted visit us in November 2019, we only had 3 recommendations, and one of which was about IHAs. And that's because the initial health assessments at that time were very poor in around the 20 and 30%. So it shows how far we've gone in really a year, that those initial health assessments are now much more timely than that. Obviously, we still strive to get it even higher, but the joint working is really paying off. And you know, as you say, we need to keep that going. I know from Children's Social Care, very pleased with how the partnership's working, and we problem solve in those weekly meetings, which has seen, I think, the result being that children's health needs are being assessed and hopefully met quicker.
Thanks, Sheila. I mean, in principle, having the joint LAC position that Stephen mentioned seems to me to be quite an excellent idea. further break down silos. I'm far more sceptical about this being done on a Essex South End Thurrock basis. One of the reasons that we chose to be a unitary is because as a smaller unitary, we have far greater scope to know all of our children and to have that face-to-face contact with our children, far greater than a sprawling county council model. So joint LAC certainly sounds like a good idea, but I'm very, very dubious about the idea of a set wide arrangements. Helen, that you?
Yeah, hi Chair, thank you. I've been leading on the scoping of the set-wide IHA model, and we're at a very, very early stage. An initial paper is going to HEF in February, and just to reassure, I think what we heard back from partners and stakeholders across this, it's a pan-Essex actually conversation that's going on, is that where there might be, certainly there was a view that there might well be advantages to having a centralised administrative centre with one point of contact, and then maximising the resources that we have across. I think what we've found locally through the work that's gone on over the last year, that the issues are very fundamentally based, I think, against the belief that it was a resource issue with paediatricians. I think it actually turned out to be very much a process issue, and I think that's what we're trying to unpick. I think at a pan-Essex, but I think it's worth exploring the conversation, but no decisions have been made as to the sort of outcome of those recommendations as yet. I think definitely I'd echo the challenges around when children are placed outside of the Nelft catchment area, and I know the AD in Nelft is, that's through her personal tenacity and ringing outside area providers to really push and challenge them on terms of that provision, and that's what's really made the step change. But in reality, that's not a sustainable model. I think we'd agree. We need to be having effective dialogue that doesn't need personal chasing for that. When children are placed outside. So there are some advantages, but there are definitely some considerations and risks to doing things at scale. James.
Thanks very much, Helen. That's helpful. Could we ask then that before decisions do get formally made in that regard, they do come back to Health and Wellbeing Board first, please?
Absolutely, James.
Thank you. Any final comments? Wonderful. Well, thank you very much, Stephen, for a very good presentation, and we look forward to seeing how plans develop. Now, I'm conscious some colleagues are messaging me saying that 1 o'clock is a fixed deadline for them to leave. So I'm just going to amend the running order slightly. So if we can take the dementia strategy next, and then the sexual abuse strategy. So on dementia, Catherine.
Thank you, Chair. Yes, I'm presenting this today as our overarching dementia strategy for Southend, Thurrock and Essex. Needs to be refreshed. It was a strategy that was developed together and comes to an end this year. We have had that overarching strategy since 2017, but we have had a local implementation plan that sits under that. So just to reassure, obviously, I know there are concerns about undertaking pieces of work together at times. I'm very pleased that we have our chair of the Dementia Action Alliance here today, who I'm sure will be able to offer some insights into some of the positive progress, but also some things that still need to be addressed. So the consultation will be in two parts. We will kind of review the strategy to date and see where changes might need to be made and improvements. But we'll also, once we've done that, we will have a look at how the current situation has been affecting people with dementia and their carers and families. I think the pandemic has caused a lot of difficulties for people because some services have face-to-face services have not been available, and I think that has really made people rethink how services are provided. So we are going to kind of look at more imaginative ways to actually consult with people. Clearly, we'll do the kind of usual thing of using our portal, writing out to people, but we'll also want to see if we can do some work more face-to-face with people, and whether that is virtually or physically face-to-face, if we're able to do that as the lockdown might be eased. I think that will be really positive to get people's views about how services are being delivered currently. I think the other thing just to say is once that's been pulled together, we would want to ensure that any draft of the strategy was circulated widely and commented on, and there will be a steering group that will be formed across the whole of Greater Essex, but we will ensure that people who use services and their carers and partners are involved in that. Our local implementation plan has achieved a few things. Our crisis intervention has been very positive. The work with the Alzheimer's Society, very good. Supporting our care homes around dementia, again, has been a very positive development. But I know there's still quite a lot to be undertaken. So that's why we want to refresh the strategy and make it as pertinent as possible to the times now. And I'm sure our chair of our Dementia Action Alliance, which was another very positive thing that came out of the strategy, would want to comment on the state of services currently. Thank you, Chair.
Thank you very much, Catherine, for your presentation. I'll bring in Pradip in just a second. The one marker I just wanted to put in the ground for the dementia strategy, you remember a few years ago that there was the mooted idea of perhaps the construction of dementia villages. I'll just remind colleagues that I remain adamantly opposed to dementia villages. I think we need to do far more to support people with dementia, remaining as independent as possible, support people with dementia, maintaining a active and happy life in regular society, and making sure that regular society and the world around them is suitable and fit to support people with dementia. I don't think simply putting them all in one area is a particularly wise option. So please just bear that in mind as we have those conversations. We want to see integration, and we want to see support for people with dementia, not just distanced provision. But Pradip, I'm sure you've got plenty you wish to share with us.
Yes, thank you, Chair. And Catherine, thank you very much. It's nice to see you on board. It's early days for me, but exciting times ahead. I'm reviewing the action plan that's been approved by the head office, so that's something that it's a starting point. I'm quite passionate about regenerating the DAA here. There's a lot of work to be done. We are working on dementia-friendly communities and reaching out to as many organizations here. And Councillor Holden knows that we're starting with the council. Again, I echo with what you're saying, Councillor Holden, in terms of the support that's needed in the community. Certainly, first and foremost, with the COVID, it has been very difficult because our support was based on face-to-face interaction. But now with remote, we're looking at other alternatives. During the pandemic, it has been, I think, noticeably difficult to try and reach out to people. They are isolated, and particularly for the carers, we're trying to disseminate information about how they can best look after the loved ones. So certainly a lot of work to be done, and it'll be good to keep in contact again. And there's a lot of initiatives that I'm bringing to the table, so I'd like your support as much as we can work on it. I know, Catherine, that my superior, Mel Williamson, is working with you on the strategy. So hopefully wherever I can put an input, do please reach out.
Thank you.
Thank you very much, Board.
It's always good when someone says, I understand such and such is in contact. When you see nodding heads, that's always a good sign. It's when you see total confusion, you know something's gone wrong somewhere. So excellent. Any other comments on the dementia item? So Catherine, it might be worth that as Prady goes through the process of, as he says, hopefully regenerating the DAA in Thurrock, if we could try and, as they start to get back on their feet, maybe have a dedicated meeting with them to go through the strategy, because I'm sure they may want to take a more nuts and bolts approach than a more probably a longer focus than just the board can right here and now.
No, that's fine. I'll organise that. Thank you.
Brilliant. Well, thank you very much, everybody. Conscious of time, so I know we've got Greg, who's an external guest from the police. So if we move on to the sexual abuse strategy, which Priscilla and Greg are going to present, although I think on your icon on here, Greg, Middleton is actually spelt wrong. I think it's spelt with a Y.
Oh yes, yeah, no, it is spelt with a Y. Yeah.
Just to make sure we're paying attention.
Exactly. Yeah. Keep everyone on their toes. Roger, how many spelling mistakes was my last annual report when I was the cabinet member for education? 17.
Gosh, can't remember. Quite a few.
Someone alerted me just before full council, so I quickly rushed out a press release, slightly tongue-in-cheek, saying I've deliberately inserted 17 spelling mistakes to ensure that the opposition actually read the text. Right, sexual abuse strategy. Greg, do you want to lead off?
I think Priscilla's going to give an introduction. On you, Priscilla.
Yes, I am. Thank you very much, Chair and Greg. It's just a very brief introduction as to how the strategy came to be, and then Greg will go through it in a bit more detail for you. I appreciate time is of the essence, so I will move on. As the Violence Against Women and Girls Coordinator for Thurrock Council, I welcome the addition of the first Essex-wide sexual violence and abuse strategy. This strategy was developed using existing resources, which included Thurrock's VORG strategy and the Joint Strategic Needs Assessment on Sexual Violence and Abuse, which was led by Thurrock Public Health. Local partners have been key in contributing to this strategy, including CEREC Specialist Services, who are part of the Synergy Essex group, and they continue to support this strategy through developing the action plans that are going to underpin it. This will contribute to the Council's priorities in relation to people and also to the health and wellbeing strategy's new proposed domain in relation to the wider determinants of health. The strategy was recently endorsed at the newly formed Thurrock Sexual Violence and Abuse Board, which is leading on the implementation of the JSNA recommendations. And through this board, we are going to continue to explore our collaborative opportunities for our shared priorities so that we can ensure as much as we can that those who have suffered sexual violence or abuse, or those who are still suffering sexual violence and abuse, can access the support that they need. So if you don't mind, Chair, I will now pass to Greg to go into the paper in a bit more detail. Thank you.
Thanks, Priscilla. Thank you for that introduction. And thank you to colleagues for giving us some time on the agenda to talk through this. I won't take up too much of your time because I'm conscious that people will have already had an opportunity to read through the paper and have a look at the strategy. So what I'll just do is give you a quick verbal update which summarises the paper, and then an opportunity for questions or clarifications if you have any. So the strategy itself is, it says in the paper there, it's the first attempt to bring together a partnership strategy that focuses on sexual abuse. You'll be aware that there is a domestic abuse strategy which covers Southend, Essex and Thurrock and all partners, so police, local authority, health and others. But we haven't done this for sexual abuse previously, so this is the first attempt to do that. And I think kind of learning from the experience of domestic abuse over the last 10, 20 plus years, it's trying to really make a cultural change in the way that we view sexual abuse. So we're not simply trying to tinker around the edges, if you like. This is trying to make fundamental change, and I'll come on to the strategic aims in a second. But it's trying to break the taboo of sexual abuse, so get people understanding what sexual abuse is, able to talk about it, willing to disclose, willing to seek support, willing to go to the police to report it, so that something can be done about it. That's really the aims and ambitions of this strategy. So we've categorized 5 sort of outcomes or aims, which are quite wide-ranging. They start at the very beginning, which is to prevent abuse happening in the first place. That has to be the ultimate goal, to stop these things happening in the first place. The second pillar is to support victims. So where people have been a victim of sexual abuse or sexual violence, regardless of their age, regardless of their gender, how can we make sure that we give them the support that they need to deal with, to cope and recover from the experience that they've had. There's something around the criminal justice system. The report makes reference to the fact that we have a really poor, not in Essex, this isn't an Essex or a Thurrock issue, but nationally and internationally, we have a really poor rate of people disclosing and then cases going to court and resulting in convictions. Something like 2% of rape incidents end up in court, and with a successful conviction. So how can we make the criminal justice system better? How can we make it work for victims of sexual abuse in a way that it doesn't appear to do at the minute? It doesn't seem to achieve justice for victims. What can we do in terms of communication? So that point about breaking the taboo. How do we get people to understand what consent is, what sexual abuse, how it manifests itself, and what good healthy relationships look like? How can we have that conversation with the public and with partners and referral agencies? What can we do around that? And then finally, what can we do to tackle perpetrators directly? So recognising that we can put lots of victim support arrangements in place, but if we don't do anything to tackle the people who are actually perpetrating these crimes, we're likely to find that they'll go on and continue to offend and perhaps escalate their offending behaviour. So what can we do to, tackle the root cause of these issues? Obviously, the recommendation speaks for itself. We're looking to get endorsement from this board and consider, within individual organisations, what can be done to tackle this and improve the situation within Thurrock and across the whole of Southend, Essex, and Thurrock. In terms of the timing of it, I think it is really timely because we have seen an increase in the number of people reporting, the number of people seeking help, in light of fairly visible cases coming through the court process or being disclosed and coming into the public realm. So we have seen people seem to improve their understanding of what abuse is and therefore look to seek support or giving them a bit more confidence to come forward and report to police perhaps. But there's also a lot of other work going on. The Home Office are currently reviewing and revising their VORG strategy. The NHS England a couple of years ago put out their strategic direction for sexual abuse. So there's lots of things happening within other organisations. And I should reference, Priscilla's already mentioned it, but Ian's on the call, the really good work that that was done by Public Health within Thurrock on their sexual abuse JSNA. And I would say, and I have said this in other forums, I'm not just saying it because I'm in this meeting, but Thurrock have really, for me, kind of led the way in terms of recognising the impact of sexual abuse and seeking to put it on their radar. Other parts of Essex haven't got a VORG strategy, for instance, and perhaps haven't done the amount of research and work that Thurrock has done around sexual abuse. So credit to all those involved who've kind of made sure that this agenda is actually relevant locally. Priscilla's already talked about how the strategy was developed and the consultation that we have undertaken, but just to flag, it has been to the Health Executive Forum and presented there, been to chief execs, leaders and chief execs, and a number of other forums. So we have done a lot of consultation around it. So I won't go into that in any more detail because that's already included in the report. I think the thing I would just conclude by saying is next steps. So we are in the process, and Priscilla's involved in this as well as Ashley from Thurrock. It's a task and finish group which is looking into how we take this strategy, which, you know, if you've had a chance to read it, you'll recognise is quite high level. How we take those strategic aims and take them a level down to say, okay, what are we actually going to do in terms of actions? How do we action a lot of these ambitions, and how do we measure the effectiveness of this strategy? So we're currently working on an action plan and a performance framework to understand the effectiveness of the strategy and what we're actually going to do about it to implement some of these high level strategic ambitions. We're expected that to be complete in a couple of months' time. By the end of the financial year, we're hoping to have at least a draft version of that action plan. We'll continue to socialise the strategy as well. We'll continue to take it to different forums, try and get it on as many agendas as we can, and try and get as many organisations as possible to sign up to it. I think probably everyone on this call would recognise sexual abuse, like many of the issues that you've talked about today, and we talk about in a lot of these forums, isn't something for an individual organisation or agency to deal with. It has to be tackled collaboratively. It has to be tackled in partnership. So we'll continue to bang the drum for sexual abuse and improve the way that we deal with it, and hopefully make a real impact for those people out there, victims and residents who are impacted by it. Thank you, Chair.
Brilliant. Well, thank you very much, Greg and Priscilla, for your presentations. Are there any comments? No hands up at the moment, so I'll go first. Probably a question for Greg, I suppose. On the data side of sexual abuse, I know one of the things that our youth offending service flagged was where we mercifully have quite a low rate of certainly youth offending in regards to sexual crimes. It's difficult always to predict the parts of the system that might be failing to detect sexual abuse because the cohort is quite low. So my understanding is the reason that we have an Essex strategy opposed to just a Thurrock strategy is that we've got more data, and is it easier therefore to look at parts of the system and evaluate what parts of the system are safeguarding people from sexual abuse, what parts of the system are helping people recover? Is that the rationale for an Essex-wide plan rather than a Thurrock-specific one?
Yeah, that's a really good example actually about the benefits of a county-wide strategy. I mean, I think I would also say that there's no attempt to replace the Thurrock Vorg strategy with this strategy. It kind of complements. It's not intended to usurp the existing local strategy. But there are some examples. So police activity, for instance, is a good example where that, you know, as an organisation that stretches across the whole of the 3 local authorities, the actions which come out of the strategy for Essex Police, which they will adopt on a county-wide basis. There may be some local variations through community policing teams, etc. But it's easier to implement on a county-wide basis because those organisations sit across those boundaries. And some of the examples that we've seen from domestic abuse, for instance, is where communications campaigns around awareness raising have been run. We've been able to do those across a larger area and make some efficiencies, but also make sure that there's consistency of those messages, and the support arrangements that we have in place are county-wide. So it makes sense for our communications and, like you say, data collection and all that kind of stuff to be county-wide as well.
Thank you very much, Greg. Mark Tebbs?
Thank you. It was just a question on the kind of the scope of the strategy. So particularly picking up on the kind of objectives and the link with kind of mental health treatment services. So obviously a lot of kind of presentations, mental health presentations, personality disorder, serious psychosis, etc., have roots in kind of sexual abuse and violence. Do you see this strategy as being kind of part of shaping that, or kind of outside of the scope of this strategy?
It's a really good question, Mark, and kind of acknowledge the links between mental health and sexual abuse, particularly that historic sexual abuse. I think in terms, so answering your question directly, I think scope-wise, it's probably out of scope thinking about the wider ramifications in terms of mental health. But I could think of if we think of sexual abuse in a domestic abuse context as well, there's obviously lots of crossover there. I think it probably would get a bit too complex if we tried to include domestic abuse and like mental health, and substance misuse, things like that. It just starts to become a bit too big of a product. But there's definitely something, and maybe that's something that we can take back to the sexual abuse partnership to think about how because we do have conversations about links to mental health and domestic abuse and those other agendas. I definitely think it's something that we need to consider. And now that we've got the strategy, maybe it gives us a bit more opportunity to have those discussions about how does this link in with other strategies and things. But it can totally take the point that there is definitely crossover with that area.
Brilliant, thanks, Greg. Any other comments? Or Greg or Priscilla? No? Okay, well, thank you very much for the presentation. I dare say it's one of those ones that we're probably going to want to have a review at a little bit down the line. But certainly, as we go forward, I do take your point that mental health is probably strictly outside of scope, because this piece of work is more geared towards the actual the supporting of the victims and the prevention side. But I think that Mark makes a good point that there were pretty severe backlog delay problems in the mental health system before COVID. That has been vastly exacerbated. So even people with some of the most intense mental health needs are not getting seen at the moment. So I think we need to make sure that through your group, we have got that data feeding in, because it would be a travesty if victims of sexual abuse were being shunted further and further to the back of the queue of the mental health service. So certainly any live data that you have coming through, I think that would be very helpful for the board to pick up on the type of issue that Mark was just alluding to. Thank you. With that, thank you both very much. We have one more item. You are more than welcome to stay.
Okay, thank you.
Right, Catherine, is this you? I have in my head it's the the emotional wellbeing service.
It's Helen.
Helen.
Yeah.
Where you go?
Hi, James. Thank you, Chair. Thank you. And I'll be really quick, because I realise the time and partners have to go. So I won't go through in any detail, but I thought it would be useful to bring this paper to. My dog has decided to bark at this time. I'm just going to let her out and then I'll come back. Hang on.
That's fine. Sheila, entertain us in the meantime, please.
The joys. Never mind. Okay. So I just thought it'd be useful to bring this paper to the Health and Wellbeing Board. It's gone to Brighter Futures Board a few months ago, and it was very well received. And the recommendation was that we felt it'd be really useful to share it to members here as well. So it really. The aim of the paper is really twofold, really. One, to provide assurance around children's mental health and the work that's going on, and also really to give a flavour of the ambition going forwards, and very much echoing all of the themes really in every single item on this agenda today in Health and Wellbeing Board, around place being very important, that the integration of services wrapping around the needs of children and young people in this case is the ambition, and certainly the ambition that we're going to be looking at very carefully in the refresh of the Brighter Futures strategy that's currently being drafted. And it won't be a surprise to many people on the call that emotional wellbeing and mental health is a key area in that strategy that we're focusing on. So the paper really describes that actually, despite the COVID-19 and the pandemic that we've been working through, that all of the mental health and emotional wellbeing services available in Thurrock, whether they're being commissioned by council, CCG, and our voluntary sector, have continued to deliver their services and deliver them very well, actually under exceptionally difficult scenarios. They've adapted their model of delivery. They've been flexible. They've been reaching out to children and young people and families proactively. And I think we've had many sort of positive stories. However, there is a lot more work to do, and there are several papers published at the moment and reports coming through that is highlighting the urgent and prolonged needs of children and their emotional well-being and the impact of the pandemic. And I think people are definitely measuring this in terms of years to come rather than the next weeks and months. And I think that's really important for us to note strategically so that we plan accordingly to that need. And we plan as a system, and by system I mean the system within Thurrock across all of our providers and our assets, both community and those more traditional agencies, and we hold it and consider it as a whole rather than as individual service provision lines. For example, and we've got some great examples within Thurrock where we've done that incredibly well. I think if I give you an example, our youth offending service, for example, has now a really robust integrated approach with our youth offending managers. We've got a speech and language therapist in there now. We have a dedicated CAMS worker or our mental health worker in there, and we've got educational psychologists all wrapping around the children in a seamless service. And I think there are other examples that we've done in Thurrock that we need to learn from and build on going forwards. So the paper lays out individual service provision, and I'll just highlight a few, and those that are particularly new. One is the mental health support teams in schools. That's a national driver at the moment, and we have commissioned that through NELFT, and we've seen that has given a huge advantage to that connectivity between schools and the mental health service provided through UMES, which is a key message that we received from our schools when we spoke to them and young people, that communication line can be enhanced. And certainly even in the very early days, they've only gone live in September in the middle of the pandemic. So if you like, despite everything, they managed still to go live and deliver services with our schools, and the response has been really positive so far. They're working really closely with our schools wellbeing service, and that's a jointly commissioned service working on a whole school approach. So for Thurrock, in terms of that localising that model, that connectivity and relationship was formed very early on. And NELFT have done a superb job, and Jill's on the line, I won't embarrass you, but they've done an absolutely superb job at turning around some incredibly tight timelines in order to meet the national requirements. And we're just talking to NHSE actually later on today, and there's definitely possibilities of more teams coming online over the next 3 years. So that's such a reassuring message. Our national lead was telling us for the NHS, the mental health support teams in school is the biggest investment area for the NHS in England currently. So it has a big profile nationally, and we want to make sure it has the best impact for our children and young people going forwards, so it's sustained in the long term. I'll let Jill talk about the UME service a bit when I've finished, but I'm just going to mention the infant mental health services that equally has gone live during this time, and that we mustn't forget, we obviously focus on our older children, but we mustn't forget our under fives and our youngest in our population. And we know that during COVID, mums have continued to give birth. That's something that doesn't stop. And that we've had over sort of 3,000 births in this time during COVID, and all those babies have been born into families in lockdown, reduced social support, reduced social interaction, and our normal services have been having to deliver in very different ways. And I think there's definitely a concern around the impact long term on the development, and certainly in the perinatal mental health field around mums and partners coping with quite a life transformation at this time without that support network around them. So I'm going to stop there because I could go on for a long time and just hand over to Jill for a few minutes, and just she can update on UMS and their particular findings, perhaps around the crisis, group of children in crisis that you're finding, Jill.
Thanks very much. Can everybody hear me? Yeah.
Yep.
Okay. Yeah. Sorry, Councillor Arnold. I thought you have yourself on and off mute so many times. So thanks to Helen. That was a really good overview and a great paper that Helen had put together for Brighter Futures Board. So just in summary, a couple of brief points I just want to mention. I mean, I know it's very easy to say this in a couple of sentences, and I always think it never really gives the kind of glory that is whenever people have tried so hard to keep the show on the road big time during COVID. But all our mental health services have continued to run business as usual. That being said, we have had to do things in a slightly different way, including digital contacts. That has, however, increased our performance in some areas where we're able to see more patients, albeit see them digitally. We do still see people face to face where required, particularly around the SEND agenda, where there are children that doing a digital assessment will just not really meet the needs of the child and the family. I suppose key things for us are we've had to manage all the COVID challenges, people self-isolating, staff off sick, family commitments, etc. Performance is good. Acuity and complexity can be quite a challenge across the piece at the moment, but that is the same for children's mental health everywhere. We're seeing a lot of children that we've never seen before. So these are not representations, and these are not children that we suspect have become suddenly unwell during COVID. I think what's happened is the complexity and acuity. The acuity might have increased during COVID. The complexity's probably always been there. So we tend to be picking people up in crisis that we've never seen before, who can be fairly difficult. We've had a lot of increase in crisis presentations in Thurrock. I could say the same about some other areas of Essex. Sometimes we see bits of peaks and troughs with that. We've been managing our crisis team in a different way during COVID, because what we don't want is to be sending people to A&E for an assessment if we can at all manage not to do that. We've had to open up late night clinics up in some of our services that open late at night where we can see children in emergency, and that has worked really, really well. The other thing as well, just to mention, is the bit of work that we're very proud of to keep the wheels on during COVID is the Mental Health in Schools investment programme that Helen has given a really succinct outline of. That is a huge piece of work. There's a lot of rapid turnaround on that. We've managed to keep everything on track, working alongside Helen and some of our other colleagues. We've appointed a new lead for that, which is, I think everyone was very pleased about, someone who's been working with me on running that along with Helen. We'd be really happy to work hard on getting the increased investment, because it really is the way forward. But one of the things that I'll be preoccupied with now in the forthcoming year is working on some of that integration ambition across the mental health in schools work stream, the emotional wellbeing work stream, and our children's offer across the Thurrock footprint. And we've already got a meeting set up to start scoping that out. I think that's probably me.
Well, thank you very much, Helen, and thank you, Gil, for a brilliant overview. I think if you look through the paper, it's very commendable what's been done, and thank you to you both, and congratulations to your teams for what's been done through COVID. I think that there are certain things that we know we've got problems with in the system. We know that increasingly across children's and across adults, we have perhaps reached to an over the clinical model, and not enough work done across the partnership on prevention. That's certainly the ethos behind what we did with the injection of support into schools. So I think we desperately need to recalibrate that on the adult and the children side in years to come. It's the only way we're going to deal with these backlogs, short of probably a tripling of the budget. I think we also want to, just consider some of the relationships that we've had in the past. We know that that at times there have been tensions between UMs and schools. Perhaps we need to look at the size of which we're commissioning on. I don't know if it would be better sacrificing economies of scale and having something smaller, perhaps commissioned through us and Southend, or go even bigger, look at a commissioning exercise across Essex and Kent. I don't know. But I think these are options worth exploring going forward. I know we have further meetings to discuss that, and I believe I have one this evening. So I'll simply say for now, thank you for what the teams are doing and have done through this COVID crisis. And hopefully, as we work through this process, we will be able to better look at a non-clinical model and hopefully bring together the strands that UMS and EPUT represent and deal with that transitional period between adolescence and adulthood. Are there any other comments? I'm not seeing any hands. All right, brilliant. Well, Gil and Helen, thank you very, very, very much. And again, please pass on our heartfelt thanks to the teams for what they have been having to do in recent times. I'm very conscious of time. So, Darren, if it's convenient, I'm just going to take the work plan as read.
Yes, please, Councillor Auden. That'd be fabulous.
Have we lost the chamber?
There might be a delay, Councillor Horden, with chamber. But yeah,
Okay.
very happy to share
Darren
the...
Darlett says that's okay.
Yes, please, if that's all right, Councillor Horden, we'll just forward that to members later.
Brilliant. Well, thank you all very much for your attendance, and please stay safe. Thank you, everybody.
Bye.